And in one fell swoop, Republicans decide to decimate Medicaid, to pass a tax cut for the richest people in America in one big, brutal bill. This is America Dissected. I'm your host, Dr. Abdul and Katelyn.
And I'm your co-host, Dr. Katelyn.
And we're recording this on Tuesday, July 8th at 11 a.m. Eastern Time. All right, it's been a minute first. Katelyn, let's talk about happy things for a second. It was July 4th holiday. How did you spend your July 4th?
We went up to the mountains and it was lovely with some fresh, clean air. There was this really small town that had this 4th of July parade and stayed in a cabin and unplugged. It was exactly what I needed after that crazy July 4th week. How about you?
Good for you. So I marched in 3 July 4th parades in one town, which was lovely. And then I got to have a couple of days off, which was really lovely as well. I think it was the first couple of days off I've had in months, which I really enjoyed. Got to hang out with the girls, and we did some fireworks with neighbors. We grilled steak. We did all the great American traditions as Donald Trump was gutting Medicaid. So let's go ahead and get on to that. So the big ugly bill, which Republicans passed last week, will take Medicaid away from an estimated 12 million Americans over the next decade. And I'm sure you've heard that stat thrown around in the news. We wanted to spend some time here just talking about how that's going to materialize. So they're starting this in 2026 in the most politically sneaky way. They're starting this after 2026, after the midterms. And what will happen is not that Medicaid will just go away. It's that people are going to have to work a lot harder to prove out their Medicaid access. They have to prove that they're working or volunteering or attending school at least 80 hours a month, or they have to have an exemption, such as caring for a child under the age of 14. And then they're going to have to do this every other year. So here's the crazy thing about it, right? Katelyn, you and I have spent so much time talking about how DOGE was gutting government under the auspices of trying to address quote unquote waste, fraud, and abuse. And what this is going to do is literally build the most wasteful government bureaucracy specifically aimed at trying to cut people off of Medicaid. And let's be clear, they're estimating this is going to cut costs. And so the whole point here is build an army of bureaucrats that literally tell people that they cannot have access to Medicaid. This is how this works. And it is the most insane thing because they are using the exact logic that they attempted to get credit for through this whole absurd DOGE project. And this is going to be absolutely devastating for a lot of people. So Katelyn, can you give us a little bit more insight about exactly how devastating this is going to be?
Yeah, it's going to be felt. Like you said, it's going to take years, but people are going to feel it. These provisions, the bill basically assumes that fewer people will be on Medicaid because they're unable to comply, like you said, with missed paperwork or this complex system. Bill also directly cuts the amounts of federal money allocated to states. And so states are going to have to figure out how to fill that funding gap. But altogether, you're right. The federal government's going to save $1 trillion, I guess, over the next 10 years. But it's going to have real world impact on Americans in the short and long term. Like you said, up to 12 million Americans lose their Medicaid coverage, which means delayed care, it means higher healthcare costs in the long run, and it includes death. There was this Yale study, I don't know if you saw it, Abdul, that showed 52,000 preventable deaths per year because of this. I mean, but then also it's going to trickle into the healthcare systems as well, right? So in many of these communities, Medicaid is the largest payer for hospital services. So when patients lose this coverage, they don't stop getting sick, right? They now show up at a doctor's office or emergency room without insurance. And many hospital systems are already very close, especially in rural areas, on the brink of financial collapse, which means this bill could push them over, leading to layoffs, service cuts, closures. There's this policy analysis that found close to 400 rural hospitals are at risk to being closed due to this. And so, yeah, I mean, it's gonna be felt. I mean, this is the largest, most significant change in our healthcare system since the passage of ACA. But like you said, instead of moving towards healthier, more prosperous future, this bill chose to do the opposite. So, Abdul, you literally wrote a book about our dysfunctional healthcare system. So, take it from here. What really happens next?
So there's three things I want people to pay attention to. The first is this doesn't just affect people on Medicaid. If you are insured, you're still going to pay the costs, particularly if you live in a rural or urban community where a large proportion of the population gets their health insurance through Medicaid. Let me just explain how this works. It's not like you can't get healthcare if you don't have health insurance. It's just that you get it in the least efficient way possible by going to the emergency room where you're protected by a law called EMTALA, or the Emergency Medical Treatment and Labor Act. It basically means that you cannot refuse care to somebody who comes into the emergency room and needs it. But that care that goes uncompensated, which means that there are two groups who end up eating it. One is going to be hospitals. And so those hospitals are going to have to carry the weight of healthcare that they had to provide in the least efficient way possible. And two, they're going to try and pass some of that cost back onto you in the way that they negotiate health insurance. And so health insurance companies notoriously pass that cost back onto you in the forms of things like deductibles or copays or premiums. And so we're going to have to pay the cost of care for people who otherwise should have gotten it via Medicaid. All, remember, so that they could pass a tax cut for the richest people in America. But then what's that going to mean, particularly for rural and urban hospitals? It means that a lot of them, if they're going to have to eat the cost of that healthcare, a lot of them aren't going to make it. It's going to lead to healthcare closures. I think about my state here in Michigan, 64 rural hospitals, 13 of them are already at risk of closure. That means that if you're insured, you need somewhere to use your insurance. And if your rural hospital closes, you're driving an extra couple hours in the case of a heart attack or a stroke. And in those situations, that can mean the difference between life and death. But for providers, it also really sucks. That means you can't provide care for people out in the outpatient setting if they're not otherwise insured. And it also means that you're going to be providing a lot of uncompensated care. Because remember how this works, right? You provide care expecting somebody to have Medicaid because they had Medicaid, except for you've now created all of this bureaucracy and this paperwork churn that's going to kick people off their Medicaid, meaning that they're not going to be able to reimburse you for the care that you provide. And if you're already one of those rural providers, that's a big challenge for you because we're having a hard time keeping rural providers in rural communities in the first place. And then the other part of it, right, is that it messes with state budgets, right? Right now, Medicaid is a joint partnership between federal government and state government. And this pushes more of the Medicaid cost onto state government, which of course is going to displace a lot of the other things that state government is expected to provide. It also mucks with ACA plans by cutting some of the federal subsidy for those plans. So this is all around bad deal. It's bad for you if you're on Medicaid. It's bad for you if you're a rural or urban hospital. It's bad for you if you're a provider. And it's bad for you if you're insured and just trying to get healthcare in your community. This is just bad. It's cruel and it hurts people. Katelyn, what more is there to say about this?
I mean, I want to go back to what you were saying, Abdul, about the lack of efficiency, because you're right. I mean, the justification for this bill was a fraud and abuse and waste. And I think everyone really agrees that we should address fraud in public programs. But this bill assumes it's all on Medicaid recipients, which is wrong, right? Most fraud actually comes from providers, not beneficiaries. There's this every year we do this federal healthcare fraud enforcement report in the United States. And the last one, which was in 2023, showed no cases of beneficiary fraud. And other examples were like a Texas ambulance company billing for, fake ambulance runs, a Kentucky pharmacy charging for unfilled prescriptions. I mean, we can go on, but that's where the most fraud is. This bill is not going to address that. And I think the other part of this efficiency formula is that we need to recognize that Medicaid is one of the most efficient forms of government insurance. Getting rid of it means a less efficient health system. There was this great study in Health Affairs in 2020 that I thought was fantastic. And it looked at Medicaid beneficiaries, and they had a 20 to 30% lower healthcare spending than those on private insurance after controlling for poor health status. They had fewer outpatient visits. They had lower rates of prescription drug use compared to privately insured individuals. And so there's this cruelty of the individual and the systems that are going to feel this, but also not moving towards a healthier America. Like in a more efficient and a better health ecosystem that like lifts people up in an efficient way is just not what's happening here. And it's really, really hard and frustrating to watch.
Yeah. I mean, this is gutting people's healthcare at the point that they need it. I mean, that's the thing about it. Like the only way this
Yeah.
saves money is to stop compensation for healthcare that people need. Like that's the only way this saves money. And so they're actively playing this game by saying that they're not cutting people out of Medicaid. They're just requiring people to work for it. But the hard part about this is the only way this bill saves any money is because you literally took away compensation for healthcare for people who need it. And that means that a lot of those folks are either going to think twice about getting care that they needed, to your point, Katelyn, about how important that care is for long-term health and well-being, or they're going to fall into huge amounts of debt, which, by the way, is an
Yeah.
albatross on the economy. And this is the other part of it, is it's not even that like this was the only cut, right? And I want to move on to some of the other aspects of this bill that I think are really important for us to touch on, right? First, I want to talk a little bit about what's not in the bill. It's not like we're increasing budgets for things like the CDC or the FDA, agencies that keep people healthy in the first place, or investing in NIH-based research. That's not what's happening here. And we know that given what's happened in DOGE, each of these agencies is functioning at far less than the capacity that they were functioning at before Trump took office back in 2024, which feels like 5 years ago now.
And this isn't the fiscal year 2026 budget either. I mean, we're going to have huge cuts to those coming down the pipeline as well in October, if that passes as well.
Yeah. No, this is devastating. You've been tracking the cuts to the SNAP program. Can you talk a little bit about that?
Yeah, so SNAP stands for Supplemental Nutrition Assistance Program. It's used to be known as like food stamps, for example. And these same Medicaid requirements around working and around reporting and around proving eligibility for Medicaid will apply to SNAP recipients too. It reduces federal reimbursement for state administration costs, will likely reduce states' capacity to actually run this efficiently. And then also it cuts and eliminates SNAP education, the education arm of SNAP, to help educate on the importance of healthy food choices. So we're not only going to have a lot of people without medical health care, we're going to have a lot of people, I think the estimate is 3 million children without SNAP benefits to actually pay for food to keep them healthy. So it's I don't know what to say as a mom. Like
I mean, it's like, imagine being RFK Jr. and talking about how you want to educate people to eat healthier, and then being a part of an administration that just cut one of the most important programs to do that. I mean, I don't know whether they're going to refer him to RFK Jr.'s Instagram page. Like, this is, it is such a masterclass in how you use public discussion, mis and disinformation to hide what the real agenda has always been. And that's what you get. It's what we keep getting out of this administration.
Well, you mentioned RFK. I was actually watching to see if he was going to say anything during all of this, because you're right, this does not make them healthier. Yeah, there was really no mention of this. In fact, he was tweeting about removing health dyes from some foods while this was passing. So not really taking this very seriously at all. But other than Medicaid and other than SNAP, this bill changes the rules also for student loans, which will have implications for public health and medicine in the United States. Abdul, how is it going to affect students?
Yeah, so back in my professor days, I wrote a book alongside a med student called The Color of Debt. And what we wanted to understand was the impact of race on student debt. We know that young people from lower income families tend to have to take on more debt to pursue an education generally, but particularly to pursue a very, very high cost graduate education like medical school. And there's a somewhat ignored aspect, given all that's bad in the big, ugly bill here, of the impact that it has on student loan coverage. So just to give you a sense of this, right, the average medical school grad, right, will have to take right around $250,000 to $300,000 in loans. This sets a cap of $200,000 on medical school loans. So if you or your kid want to be a doctor, you're not going to be able to cover the last bit of the cost of that via loans, which basically means that they're now pricing people out of a medical education. This, by the way, in a moment where they've taken away a lot of the indirect costs from the NIH that funded a lot of medical schools, that allowed those medical schools to start offering, right, lower cost or lower tuition options for lower income students. And all that means is that you're going to have a less diverse pool of
Yeah.
clinicians. And that's adding to the fact that we already have such low diversity as it begins. People from working class backgrounds, Black folk, Latino folk, we're just not seeing as many of them in medical school as would be representative of the population. This is about to make it a whole lot worse. And we also know that having a diverse practice pool matters, particularly for patients of color. And if you don't see yourself represented or your experience is represented in the people taking care of you, it undermines a lot of the trust that you might have in the system. So this is all bad, and it operates in ways that are just mean and cruel. And I got to tell you a personal story. I was a student in the UK when they first introduced student tuition fees. So back when I was there, back in 2009, before this happened, going to university in the UK was free. Imagine that. And they introduced a £9,000 tuition fee. And I was tutoring what they call A levels, which would be like the equivalent of AP courses. And I was tutoring A level biology and chemistry. And the most promising student in my course was a kid who just watched his future get priced out from underneath him, right? I asked him, I was like, so where are you going to university? He said, I'm not going to university. I was like, I'm sorry, what? He's like, yeah, I was planning to go to university, but I can't afford the £9,000 to go. My family is uncomfortable taking loans because that infrastructure just doesn't exist in the UK because this didn't exist before. And that means that I'm just not going to go to university. And this has real impact on our lives. It has impact on creating an opportunity for the best and brightest to go and invest themselves in taking care of other people. And so this is just it is a really profoundly saddening thing, the impact of which we're not even going to fully feel for a couple of decades.
Yeah, and it's not just the disparities in care, right? So if students need high interest loans to fill this gap, many are going to be forced into also high paying specialties to repay that high interest debt, which means I'm most concerned about fewer primary care physicians. I expect this is where we're going to start seeing even more of a shortage than we already are. And that is a huge problem because they're the front door of our health systems, right? The ones that catch problems early, manage chronic conditions, keep people out of emergency rooms. So I think that this will not only have those direct impacts that you're talking about, Abdul, but also may even mean worse health outcomes, higher costs, more strains on the system.
Yeah.
And it's going to affect everyone.
It is. And I appreciate you bringing up that point about specialty choices, right? Because we don't really fully take into account what the overhead of having $250,000 to $300,000 in loans means for the choices you have to make about your future today, and what that means about how you
Yeah.
you decide what kind of specialty you want to work in. I do want to switch gears to talk about an unfortunate marker in the measles outbreak that we've been talking about. Over the weekend, the U.S. hit 1,281 cases, 1,281 cases. Katelyn, can you tell us why that number is so significant?
Yeah, it's plain and simple. This is the highest number of measles cases since we declared it measles eliminated in 2000. In fact, it's the highest number of cases since 1992, over 30 years ago. I think it comes at a really interesting time that we have RFK Jr. as our Health and Human Services Secretary, which I think is a symptom or a correlate of what we're seeing with disease across the nation. And what this basically means is that we're going to see more and more cases as we go because vaccination rates are decreasing. Measles is the most contagious virus on earth, so it's typically the first to resurge when vaccination coverage declines. So I don't think it's very surprising that we're seeing lots and lots of measles versus like polio, which has a lower herd immunity threshold. One thing that I'm paying attention to right now is our elimination status. The elimination status is given by WHO that basically tells other countries in the world that measles is not endemic in the United States, that we do have these outbreaks, but they're seeded by international travel. But we could lose that elimination status, and we lose that by having a sustained outbreak for more than 12 months. And we're on about month 6. So it's very big possibility that we lose that elimination status, and measles basically becomes endemic by just jumping from unvaccinated pool to unvaccinated pool to unvaccinated pool until we figure out how to increase our vaccination rates in the United States.
I just want to put a pin in this. In our lifetimes, Katelyn, we could very well see our country go from having eliminated measles to having had it go endemic again. I mean, that's like a pretty crazy thing in the richest, most powerful country in the world. America Dissected is brought to you by Quince. I'm not into chasing trends, but I am all about stuff that fits right, feels good, and actually lasts. That's why I keep coming back to Quince. Their lightweight layers and high-quality staples have become my everyday essentials. Quince has the kind of stuff you'll actually wear on repeat, like breathable, flow-knit polos, crisp cotton shirts, and comfortable lightweight pants that somehow work for both weekend hangs and dressed-up dinners. The best part? Everything with Quince is half the cost of similar brands. By working directly with top artisans and cutting out the middleman, Quince gives you luxury pieces without the markups. And Quince only works with factories that use safe, ethical, and responsible manufacturing practices and premium fabrics and finishes. Look, there's nothing better than a good pair of loose linen pants in the steamy summer months, and I absolutely love my Quince linen drawstring pants. They keep me cool and look the part doing it. I can pair them with a V-neck t-shirt, a polo, or even a button-down. Stick to the staples that last with elevated essentials from Quince. Go to quince.com/AD for free shipping on your order and 365-day returns. That's quince, QUINCE.com/AD to get free shipping and 365-day returns. Quince.com/AD. You also noted another outbreak that we should be watching, and that's an uptick in COVID infections. Can you give us a sense of what's new there?
Yeah, I mean, so every year we've had a COVID outbreak or a COVID wave during the summer. And so us epidemiologists are paying really close attention to what the heck is happening with COVID, because COVID's been really, really low for the past couple months. And this is after a very low or small winter wave in the United States too. And so we're expecting a summer wave. And right now, we're kind of getting mixed signals of what's going on. I think we're starting to see the early signs of a summer wave. Some of our wastewater systems are showing a rise across all US regions. And we're also seeing test positivity rate increase. So I think a wave is coming. The big question is, how big is this COVID wave going to be? And honestly, I'm not too sure, because the US usually follows Europe's lead with how big the waves are. And the UK had an increase in cases, but they're started to already decrease right now. They have a very wimpy summer wave. And so I don't know what'll happen. I think that I keep keeping in the front of my mind that, yeah, we're all sick of COVID, but it's still an infant. It's still a very new virus that we are still kind of waiting and seeing how it starts getting integrated into our everyday life, if it's always going to have two waves or if it's going to go into one. So I don't know. We'll see. We'll see what happens. But I think the bottom line is that everyone over 65 needs to make sure they're up to date on their COVID vaccines, which is 2 vaccines a year still, one in spring and one in fall or winter.
And as a reminder that you may be sick of COVID, but COVID absolutely needs you.
It's not sick.
And it is going to do everything it can to find every little nook and cranny in our immunity and exploit it, because that's what these viruses do. And you can try to narrativize this away, which is kind of what the RFK approach is, but it's still a real virus. It still really infects people's bodies, and it still has the opportunity to make them sick in both an acute and a long range way. So I want to close us out here on a positive note because, well, RFK Jr., it's always good to see his plans thwarted, especially when it means a complete overhaul and restructure of health and human services. So just to recap here, he was planning to consolidate 28 federal divisions of HHS down to just 15. He's going to add a new department of AHA. I'm not even going to dignify that with a definition. Several states sued to stop him, and last week they had their day in court and won. A federal judge instituted a temporary hold. And the judge said RFK Jr., quote, does not have the authority to order wholesale changes to the structure and function of the agencies created by Congress. We don't really know what's next, but the Trump administration has not said if they're going to appeal. So maybe we get to keep HHS whole, I guess.
Yeah, there's also another case to tell you about. Good news, right? Six major medical associations just filed a lawsuit against RFK Jr. and HHS. Hey, the professional societies are gaining some courage, aren't they? They are seeking to restore COVID vaccines to the list of recommended immunizations for both healthy children as well as pregnant women. The associations included American Public Health Association, the American Academy of Pediatrics, which is coming out strong with their claws lately, American College of Physicians. There were two that I recognized that weren't on this. One was ACOG, the American College of OBs, and the second was American Medical Association. And I wonder why, honestly, and what political implications they're toying with right now. But overall, this was good news. I was glad to see big associations, one, banding together and coordinating, but also coming together to fight for these patients whose health will be impacted by COVID if they don't have availability or access to COVID vaccines.
It's good to see a lot of these folks stepping up, and just really grateful to the leadership there, because this is not something that these professional organizations have often done, and to see them sort of stepping up and taking a bit of a risk, I think is important, because this is exactly the work that's needed. Although there's one that I'm not surprised of, which is the American Academy of Pediatrics, because pediatricians are like literally the nicest doctors. Like you can walk into a room of medical students and just watch them and be like, that's a pediatrician, that's a pediatrician, that's a pediatrician. But man, when you mess with kids, pediatricians, there are very few roars like the roar of an angry pediatrician. So grateful to you for the pediatricians of the world taking care of our kids.
And they're the ones leading a lot of this charge and courage and narrative. I mean, they were the ones that boycotted ACIP, right, 2 weeks ago. So they are coming out strong, and they're coming out strong on social media too, which I appreciate, because we have to meet people where they're at and inform what's happening and potentially happening with kids' care. All right, Abdul, who did you talk to this week?
I had a great conversation with Dr. Andres Lopez from the Coalition of Communities of Color in Portland, Oregon. Their organization is doing really interesting and innovative work in community data collection. And the idea basically is that it's a way to get us beyond the basic stats of a city or county's health and actually try to center folks that tend to get forgotten in these data collection efforts. It's also a realization that not all data can be captured in the few variables that we tend to collect. And there's a lot that gets missed when we're not really capturing people's experiences and what they're sharing to us. And it's about trying to bring all these different sources together to help a community tell its own story with its own data. And I really appreciated the conversation. So I do hope that folks will stick around and we'll go from there. Katelyn, how is the weather in San Diego, dare I ask?
It's beautiful. It is 72 and sunny. We are having a heat wave, which should get up to 80 degrees. So everyone
Wow.
is freaking out over here.
80 degrees.
We're
Wow.
good. We're good.
It was like 90 all last week, and everyone was sweating their face off. So I don't know how it is that you live in the part of the country where it's somehow way warmer in the winter and also somehow cooler in the summer than it is here in Michigan. But we someday. I hear that when Donald Trump gets his way, then in the climate apocalypse that they're creating for us, at least Michigan will be like a go-to destination. So I guess there's that.
It is. I have heard about that. Same with San Diego.
Okay. So it's still going to be better. Okay, fine. All right. All right. We'll see you next week, Katelyn.
All right. See you next week.
All right. Can you introduce yourself for the tape?
Yes, my name is Dr. Andres Lopez. I use they, he, and el pronouns, and I'm the research director at the Coalition of Communities of Color in Portland, Oregon. And I believe that community data can save us.
All right. Well, can you give us a sense of, when you talk about community data, what do you mean by that? How should we understand it relative to other potential data sources?
Yeah, well, community data is data that's generated by, for, and used on the terms of community about their everyday lives. So it really is a reflection of community-centric forms of knowing, being, doing, and dreaming. It can look like numbers, words, art, music, maps. It really just sort of encompasses the diverse ways that communities share and express their truths, their lived experiences, and their desires for the future. And of course, our goal is to make it as systematic as possible, and that community is part of interpreting that and defining how that information is used.
Dr. Lopez, can you give us a sense of, give us an example of the way that you're using community data in a community to help improve the well-being of that community, and maybe how that differs from the traditional approach that we have to the way we might study a population to try and get the same ends?
Yeah, thank you. Well, there's a lot of challenges with how data is used to understand reality and to make decisions with. Governments typically rely on administrative data or census tract data, large sort of population level data. And then when you get more to the local level, there are things like listening sessions and community engagements, and of course, public testimony, right? Those are a lot of ways that community shares their truths with governments. However, they don't do a good job of tracking those truths, of aggregating those truths, and of actually using that to make better decisions and to improve the lives of folks. So most decisions made by government are actually not data informed. They are usually paired with data to sort of make a case or argument why the decision was made, but not really informed by people who are experiencing those sort of everyday realities when it comes to how we use transportation or how we get food or how we manage the healthcare system, right, for example. So I can give you an example of one way in Oregon that community is really rallying together to collect more data. So in the eastern part of our state, in the lower Umatilla Basin, there are a lot of communities there who are experiencing a multitude of health issues due to polluted groundwater and a lack of clean drinking water. Of course, these are areas that are heavily conventionally agriculture farmed and also mostly Latinx. 40 to 60% of the population of folks living in these communities are Latino, Latina, Latinx. And there's very little dominant data. We use dominant data to refer to the data that governments often rely on, which I sort of started this talking out here in this section. But there's some data like well water, for example, that helps us understand pollution, but not data about stillborn deaths and about asthma and about skin rashes and about how the local population refuses to drink the water and they buy water bottles at Walmart instead, right? There's not a lot of evidence to actually describe what's happening there, the impact it's having on people's health, and ultimately what solutions need to be implemented in order to make changes so that people are not experiencing that kind of oppression. So that's one example in our state and the water justice work that we're doing across the state, where it's really harnessing community data for positive impacts.
I really appreciate that example, and I want to read people into some of the ways that folks who think about different kinds of data have thought about them, sometimes in contraposition and sometimes in communion, in order to set up my next question. So I'm an epidemiologist, and we are on the quote unquote hard side of data. We rely on larger data sets with very systematic data collection. Now, there are a lot of limitations to the kind of inference that you can get from these kinds of data. The only answers to questions you can actually get are the ones that have data points collected on them, and that leaves huge swaths of potential rich information out there that you're not systematically collecting on. A lot of times, we are much more interested in the size of a data set than the nuance of a data set too often, which means that we will trade out getting these particular variables that may differ in a particular community for getting a broader sample of data against which you can now compare different parts. And we use statistical tools that tend to lack a certain level of complexity in order to try and get at answers to questions. And so it leaves us getting pretty broad but pretty shallow inference in epidemiologic data sets. On the other side, you end up having qualitative data where you can get very, very nuanced information in the verbiage that people use, but usually from a small number of people and in ways that are not as generalizable. And that generalizability question really is the axis on which these two groups will differ. Now, people tend to be very partisan about which of these tools is the right tool because people tend to have spent a lot of time studying how to use these tools, but they're just tools. And in the end, you have reality, and then you have whatever model you want to use to try and tell you something about reality, knowing that all models are wrong, but some are useful.
Mhm.
And so in your approach, I can imagine folks who engage in data science day to day will hear you violating the assumptions in both models, right? Which is to say, you want rigorous quantitative data and you want to admix it with rigorous qualitative data. So what kind of inference are you trying to make and how generalizable do you want to be? And what I hear you saying is actually, I don't really quite care about the answer to the question writ large. I care about an operational answer to a question that affects and helps the community that I want to affect and help, right? My question here, having given you a really, really long wind up, is how do you think about, right, your approach to community data vis-a-vis the traditional models that we think of in data analysis? And how do you speak to these different groups of people when you identify answers to the questions that they would naturally ask you about, well, how generalizable is your model, or how specific can you get if you're trying to mix quantitative and qualitative data?
Yeah, thank you. So I'll start with saying that what we need for better decision making is a diversity of data. This notion that there is like the right or best metric or approach to understanding something is very flawed. And we're also dealing with really complex social problems. So why would we rely on one tool or one approach to make broad decisions with millions of dollars that are going to affect millions of people, right? That doesn't make sense. So I'm not arguing for one over the other. I'm saying we need both and more. We need all the evidence that we can generate about what's actually happening in people's everyday lives so that we can be better informed to make those decisions. So I'll start there. Second, the generalizability question is always very interesting. You're spot on. That comes up all the time when we're talking about evidence, right? And what's trustworthy. The problem with quantitative generalizability is that it typically lines up with a number of individual units that are supposedly representative of a racial group or category that is actually made up. So you're saying, oh, if we surveyed 35 Black folks in Portland, because Black folks make up 2% of the population and that number aligns with our sample, then that's representative. And I actually don't think that's really generalizable over a group of a community that is not bounded by this sort of category, right? So I really challenge this notion of quantitative generalizability, especially across racial groups or other social groups. And what I would say about the qualitative is that it actually gives us more information about what to do. So, how do we respond to a disparity that we're seeing from a quantitative metric? What is most desired by a community? What has failed in the past that needs to look different, right? Quantitative metrics don't tell us how to do that. All they do is point out gaps and disparities for certain populations, but not how to move forward. So we actually invest so much money in maintaining these metrics and having longitudinal data sets to make these claims that we're having population level shifts and changes without actually having the context of understanding for whom and to what extent and what we should do next to actually improve that, right? So my answer is we need both of them, and that we should get away from this notion that it's generalizable, and more that each tool has its own strength, and the more of them that we can use and the more evidence we can bring, the better we can be about making better decisions, especially when it's grounded in lived experience. So if we have a survey that's capturing how people feel about homelessness in your region or how often they've eaten this week, right? Those metrics can certainly tell us about maybe how some groups are doing over others or how certain groups feel about certain realities, but it's not always grounded in their own experience. Have you been homeless? Have you gone a week without eating, right? Why are we using evidence that's not actually grounded in lived experience of people who are experiencing these things we want to shift, instead sort of broad metrics that are supposed to help us make the best decisions. So I really think we need a diversity of data, and communities' language is words. People talk about their experience and their truth through words. And one story from one person isn't anecdotal. I always sort of really get frustrated when I hear this term anecdotal, because anecdotal literally means not grounded in truth. You're literally saying the story of my abuela and how she's experienced inequality in this region is not grounded in truth, and that's not right at all. And actually, her experience is connected to all kinds of things. It's connected to all kinds of social structures, right? It's connected to how our food systems work. It's connected to how neighborhoods are organized. It's connected to who has access to what jobs and what income levels, right? So one story is actually a structural story, and it tells us a lot more. I think we really hurt ourselves by leaning into this idea of generalizability as
Yeah.
opposed to thinking about evidence more broadly.
The challenge I always had with generalizability as a concept is that it betrays a certain level of hard science envy among public health people, in the sense that usually in the biological sciences, physiology behaves the same way in the same circumstances every time. People don't do that, right? And the idea of generalizability belies the notion that people will behave the same way in the same space every time. And we do this thing to say, well, what is the truth, as if there is one way of behaving or engaging in a particular circumstance, rather than saying, what is the truth here and now? Which, if that's what your approach is, then you don't actually care about how generalizable your answer is, because
Exactly.
you want the answer here and now, not everywhere for all time, right? As if there was an everywhere for all time answer. And look, there are some pathways that work that way. Most of them in public health that we're interested in intervening on don't. And so the idea of generalizability actually is sort of this esoteric approach to science that I don't think is based in actual local problem solving. And I say this as both somebody who was a professor of epidemiology and also someone who ran two health departments in the past. Usually the questions you're asking at the health department level, you don't care if the answer is generalizable. You care if it works here and now. And does it point to me to something that I can intervene on that will beget really good outcomes for people in this particular place right now, right? Or in the next couple of years. And so I think when you can shed that, it opens up a whole avenue of being able to layer different kinds of data together to be able to get at inference that you otherwise might miss about how something's operating locally for the communities you want to intervene for. America Dissected is brought to you by Boll and Branch. Can I be honest with you? Of course I can. That's all we do on this podcast. I sleep hot. Like really, really hot. And between the late sunsets and early sunrises and the heat, I find it way harder to sleep in the summer months. That is until I discovered Boll and Branch's Percol sheets. They are cool, crisp, and breathable, so you never sleep hot again. Boll and Branch's Percol sheets are made free from toxins with the finest 100% organic cotton. They're made ultra crisp with a special cooling weave, so you never sleep hot again. They come with a 30-night worry-free guarantee. And most importantly, they're ethically crafted by expert artisans that earn fair wages. These sheets are incredibly high quality. You feel it immediately. And they've fundamentally changed the way we sleep in the summers. And unlike other sheets that start pilling after the first wash, these get better with every wash. Get the best savings of the season during Boll and Branch's annual summer event. Get 20% off plus free shipping on your first set of sheets at bollandbranch.com/AD. That's Boll and Branch, BOLLAND, branch.com/AD to save 20% off and unlock free shipping. Limited time only, exclusions apply. I want to ask because, we're living in a moment. You talked about sort of the traditional approaches to data that had been, really well funded up until about last year, or up until about a couple months ago. We're in a situation now where a lot of that infrastructure is being shut down, I think wrongly, right? I think there's still inference that you can get from a lot of these data sets, especially when you can combine them with more local community-driven data. But we have an opportunity now to potentially rethink what we think data infrastructure should look like. Mm-hmm. So if people wanted to rebuild around community data, what would that data infrastructure look like? How would we be thinking differently at the federal or even at the state level in terms of being able to empower this approach to local communities?
Yeah, that's a great question. Thank you. Well, here's the most interesting part about community data is that it's already being collected. is that communities, whenever they get together to talk about problems or their experiences, they're already capturing that information. So community-based organizations, grassroots organizations, even governments are capturing that information as folks are giving their testimony. So I think that's kind of a win for us in the sense that it's already natural for people to talk about their lived experience and what is and isn't working. But oftentimes those folks don't have the sort of tools and often even permission, in a sense, to deem their data or their experience as evidence, right? So what we really need are more tools for communities to be able to harness their own information, to be able to collect their stories, to be able to aggregate the truths and experiences, and then to be able to leverage that information to impress upon governments what needs to shift and how it needs to shift, right? So then we're not just talking about one story from one person, but we're talking about a multitude of stories from various organizations and various approaches, right? So we do need infrastructure for that. Here in Portland and at the Coalition of Communities of Color, we are building a local level data ecosystem that really sort of focuses on harnessing the community data collected by community-based organizations and governments in the service of environmental justice. And our focus for our shop is really upon extreme weather. So the ways in which folks are experiencing extreme weather here in Portland and the various ways that they would like to see different kinds of supports and programs and approaches to protecting their health, their families, and their communities. So we need more infrastructure, we need more tools, and also people need to know that they have the power to their voice and their experience is actually the best evidence we have to make better decisions. So I always think of this story when I first started this job. I met with this woman who was sort of an outreach person, and she was like, "I'm not a data person. I'm happy to talk to you, Dr. Lopez, but I don't really think I'm a data person." And I told this person, you've spoken to 300 Black families in the last month. You probably have more evidence and understanding of what's happening for this community than any other person in this region. You are fundamentally a data person, right? So I think the way that science has been professionalized and been sort of posed as something that's only accessible and that's only valid when done by credentialed experts, as opposed to it being something that really all of us can do, and that all of us are generating data every day about our experiences and about what should shift and what should change. So there's a lot of that permission as well when community starts realizing, oh, I don't need a PhD to use data and evidence to make a case for something. And it's already happening when we meet and are gathering our community for a circle talk or for other strategic planning. So those would be my answers.
I appreciate that. I want to ask because, we also live in a time when data is being weaponized against people on whom it's collected. And, the hard part about very granular data, especially narratives and stories that people can share, is that over time that they can be used against people. And, particularly when you're talking about vulnerable things that are criminalized or criminalizable, right? How do you, in the process of doing this, kind of protect people from the ways that their information can be used against them by people who might be acting in bad faith or who might be able to get access to it to use it in ways that that could be troubling or against them?
Yeah. Well, unfortunately, in our current reality, no data system is safe. Regardless of how much protection you have, there's always sort of this concern of a breach, right? So number one, we only collect what we'll use. I think that's a really important takeaway for a lot of folks. We collect a lot of information in this country that we never use. That something I call data death, right? We collect it to collect it, and then it just dies somewhere. And we got to move away from that. We should only be collecting what we're using. So that's sort of step one. Step two is that we go through a very long process of creating a data charter or creating data agreements for the ways in which why we collect the data we collect, how we'll use the data that we will use? What are the processes in which community and those who contributed that data will have a say throughout that sort of cycle, right? So we've spent a lot of times here, not just the Coalition of Communities of Color, but also our colleagues, for example, over at SUMA, doing digital justice, really engaging community to help them understand privacy and what we're going to do to protect that information, and who we will and will not work with and share that information with. So we try to create those protocols, be thoughtful about what we're collecting, and then just be honest that to some extent we just shouldn't collect some of that data because it could fall in the wrong hands, and that's just the reality.
Yeah. No, it's a sad thing that we even have to be, thinking about this in this really broken and frustrating time. Um, I want to ask, as a sort of final question, as you think about where we go from here, uh, when we think about the engagement of people in their own data collection, right? One of the worries that I have is that you really want people from in the community also leading the analysis, right? Anybody who's a scientist knows that it's not actually about the way you answer the question as much as it is about the question you ask in the first place, right? And I find us moving into a world very quickly where humans may not actually be the ones leading the question, asking, and answering. And a lot of that is going to be done via AI. And one of the things that AI seems to even more quickly be able to do than us is parse out some of the complexity and some of the ways in which, your training shapes the question you ask in the first place and then how you answer it. And AI, if it's been trained on methodological approaches in ways that allow it to mix approaches, very much akin to how you're thinking about data analysis, you can imagine a lot of this happening via AI. Now, the challenge with that is, of course, we have an interpretability problem with AI. You don't know how it answered the question or why, and then you also don't know how much of the internet it's ported into the way it asks its questions and embeds the kind of bias that is so rampant there. So how do you think about AI's role in all of this and where both community data collection and then analysis is going to go in this new AI-enabled future?
I agree. It is so important that communities are forming their own questions, collecting the data, and doing their own interpretation, which is why we've made at CCC such a clear distinction about what community data is and isn't, because people throw that term out there all the time. This is community's data, when actually community did not decide those questions. They did not collect that information. They did not use their own meaning making in that process. And so that is definitely what we're advocating for. I think AI can certainly be a tool that supports that process. When you're trying to aggregate a lot of stories and words, right? Certainly having a sense of synthesizing that information is super helpful, but it really AI really lacks the ability to make meaning, as you sort of pointed out, right? That where did this question come from? Why are we asking this question? Why aren't we asking that question? How is the answer to this experience actually grounded in a history of oppression and inequality that has a really long backstory, right? Of missteps. There's all kinds of that sort of meaning and truth that cannot be detected by AI. But we're still early on. So maybe in a closed AI, there's a way to train to think more that way, but community has to be a part of this process. They have to be centered in the process. And you're absolutely right. Questions that the dominant or governments are often asking are not the questions that communities are asking. There is such a mismatch in questions. And that's one thing that I think community data really helps us understand. It helps us get to the things that are really most important for the people experiencing the brunt of our systems.
Mm. I really appreciate that, and I think you're right. And I think as we engage these new tools, I think making sure that the ethic that is bringing us to the question is captured and well maintained in the way that we conduct the research. And I really appreciate the broader points that you raise in the broader argument about how we should even be thinking about data, right? Whose data is it? Whose questions should they be? Whose answers should they be? And who should have the onus and the opportunity to make policy out of the answers that arise? And in some respects, you're calling us to a level of almost data democracy, not just sort of operational democracy, but data democracy, which I think is critically important in a world where data becomes fundamentally more important to decision making. I really appreciate you taking the time to join us on this and share a bit more about your approach and for your leadership in this space. Our guest today was Dr. Andres Lopez, who is the research director at the Coalition of Communities of Color. Dr. Lopez, thank you so much for your time and your leadership on this issue. And we want to thank the De Beaumont Foundation for supporting this episode.
Thank you so much.
That's it for today. You can find more content at our website, incisionmedia.co. Check out our shop at store.americadissected.com for our new America Dissected merch, including our logo shirts, hoodies, and mugs. And of course, do not miss out on our Make America Scientific Again dad caps. If you have guest recommendations for the show, send us an email at info@incisionmedia.co. You can follow or subscribe to America Dissected on your favorite podcast platform and on YouTube at America Dissected. You can follow me on Instagram, TikTok, and Twitter at Abdul Al Sayed, no dash. And please make sure to subscribe to Katelyn's incredible newsletter, Your Local Epidemiologist, which breaks down the latest scientific evidence for over 300,000 followers. Search for Your Local Epidemiologist on Substack. Links to all our sponsors are available in the show notes. I really do hope you'll check them out and show them some love. They make the show possible every single week. Finally, on your way out, don't forget to leave us a 5-star review. And if you're watching on YouTube, drop us a like or a comment. Word of mouth still goes a long way too, so if you know someone who might like to keep up with everything that's happening in the world of health, do let them know. America Dissected is a product of Incision Media. Our co-host is Dr. Katelyn Jetelina. Our producer is Andy Gardner-Bernstein. Video and audio editing by Nadine Malkonian. Our theme song is by Taka Asizawa and Alex Uguera. Sales and marketing by Joel Fowler and Nick Freeman at Big Little Media. Our executive producers are Tara Knight and me, Dr. Abdul Al Sayed, your host. Thanks for listening. This show is for general information and entertainment purposes only. It's not intended to provide specific healthcare or medical advice and should not be construed as providing healthcare or medical advice. Please consult your own physician with any questions related to your own health.